For our next speaker, I'd like to introduce and welcome Dr. Kennel. Dr. Kirk Kennel is an assistant professor of medicine and a consultant in our Department of Endocrine, Diabetes and Nutrition at Mayo Clinic, Rochester. His clinical practice, presentations, and publications are focused on metabolic bone disease, including the role of lifestyle and body weight in the prevention of osteoporosis, and bisphosphonates for the treatment of osteoporosis. Dr. Kennel's primary administrative role is serving as the program director of the Clinical Endocrine Fellowship Program. So thank you, Dr. Kennel, for being here and sharing your expertise on the management of osteoporosis in the frail older adult population.
Thank you very much, Dr. Chen. I appreciate the opportunity to be here. A topic that's common to us all, I think, in our practice, assuming most in the room are internists and others in primary care and specialty care who deal with older adults. So some of my comments will be more general related to osteoporosis that I think is applicable to older adults, and some of my comments will be more specific to older adults. I have no conflicts that I'm aware of, at least. You might point them out to me, but not that I'm aware of. And again, what I hope you can do at the end of my presentation is to maybe integrate some aspects of age and life expectancy into how you evaluate and manage patients with osteopenia and osteoporosis. Describe some of the risks that are associated with osteoporosis pharmacotherapy that might be most relevant in older adults, and identify some of the optimal approaches to non-pharmacologic interventions that relate to fracture risk prevention in older adults with osteoporosis. So as you know, we have a growing senior population, and of these, a significant number may have osteoporosis, and a significant number of these may have hip fractures. So as we see an older population, we see more hip fractures. And so hip fractures being a very debilitating and expensive condition, it's a concern of ours to be able to identify people who might be at risk and prevent, as much as we can, people having hip fractures. And yet we don't seem to do a particularly good job if you just look at raw numbers in terms of how many people have osteoporosis, have fractures, and are treated. It's actually the minority. There's a subset within these who have additional elements of risk that aren't necessarily specific to bone and bone density and osteoporosis, but frailty. So things related to nutrition, physical function, that, as you can imagine, set people up for fractures and even more than just having low bone density because of things like falling. So one of our dilemmas when we mix some of these variables together is, you and I in the clinic, how do we look at people or look at patients on an individual level and define or determine who might be diagnosed, who might be treated, and how? So I'm going to share some thoughts that, again, I hope you can take back to your clinic and begin to think about how you approach these questions. So I have two cases just